Hey VesBuds, welcome back to another wonderful lecture. So we're starting respiratory this week. Speaking of which, I hope you're all well in terms of respiratory illnesses. And today I'm going to tackle pneumonia, which is a really big topic for you guys. So make sure that you have a look at these slides now and at the end of the year, and also do your own research as well. There's lots of good YouTube videos out there. Okay, so we all know that pneumonia is an infection in the lung parenchyma. So basically, I'm going to go into it in a bit more detail later, but it's basically when there's consolidation within the alveoli of the lung, as indicated by this diagram here. Okay, so epidemiology-wise, it's actually quite common, and you might know this if you've been on a gen med ward recently, because it seems that every second person has pneumonia, especially all the old people. So in terms of its seriousness, it's the #1 cause of death of infection. That's because it's so common and because it tends to affect people, which I'll go into in under risk factors. It tends to affect people who are a bit more vulnerable. In terms of etiology, the most common spread is via droplets. That's right, it's really important to sneeze in your elbow and cough into tissues and wash your hands, and or a direct transport from upper respiratory tract. So that tends to be seen in more aspiration and also intubation, and sometimes it can be via hematogenous spreads. That's if you've got like a hemothorax or any surgery or anything, but we don't really worry about that one. That's just there for completeness. So in terms of risk factors, obviously you have those with impaired immunity, for example, older people or younger people, those with HIV or other immunocompromising conditions, so cancer, that sort of thing, and vaccination status, because as I'll allude to in a few slides time, there's actually a vaccine against pneumonia, the pneumococcal vaccination that a lot of old people get. So it's really important when you're taking a respiratory history from the elderly to include that one in there. Those with increased mucus or decreased ciliary clearance, because you can imagine these people are getting more bugs trapped within their lungs and then also unable to clear it. So that's smokers. They've got decreased ciliary clearance. CF has a mixture of both, and COPD is a mixture of both as well. And aspiration, like I said, so this is old age, so you're thinking about people who, can't chew properly, can't feed themselves properly. That's also what I'm alluding to with the neuro stuff. Ethanol intoxication is a big one. There's some buzzwords for that I'll get to in the last slide. But that's basically if someone gets really drunk and passes out and vomits in their sleep and then inhales it. And then you've got post-op stuff as well, so from being intubated. Okay, so in terms of pathophys, I'm not real keen on the immunology, so I've directly copy and pasted this from last year's people. But essentially what happens is your immune system reacts to the bugs, and then your basically goes a bit crazy, and then you get edema within the alveolar capillaries. This makes recruits inflammatory cells, and then so you get consolidation in the alveoli and the ducts, and then these inflammatory cells release cytokines and you get a systemic reaction. So that's when you get the fever, chills, rigors and fatigue, which you should all be asking in your histories. And then because you've got your alveoli is filled with fluid and inflammatory cells, you're actually not able, the oxygen capacity is just not there, so you get reduced O2 transportation, which you should see on examination as well in terms of their vitals. Okay, so bugs. This is quite a big or important topic and something for you to know. Before last year, I was not really up to scratch with all of my different gram positives and gram negatives. I'd completely forgotten it all. This is probably the main condition where you have to know the bugs and you have to know the drugs, or like the antibiotics, and we'll go through that soon. So first of all, pneumonia, we'll break it down into 3 different types. So the first one is community acquired pneumonia, and obviously like it sounds. That's something that you catch out in the community. The most common is strep pneumoniae. That one's really easy to remember because it literally has the word pneumonia in it. So this one, buzzwordy, like I said, we'll go through some of those in the last slide, is rust-coloured sputum. So if someone tells you that they're coughing up phlegm, the next question you would be asking is, what colour is it? Oh, it's kind of brown, it's kind of this. Okay, it's strep pneumonia. Next, we've got Haemophilus influenzae. This one's not as common because there's a vaccination for it, but we just have to chuck it in. Staph aureus, that's more of a hospital acquired, but it can also be acquired in the community. And then you've got some atypicals. So, sorry, I should have mentioned that those first three are what we call typical bugs, and I'll go through that in the next slide, I think, or the next few slides. So our atypicals, a good way of remembering this is with the little catchphrase, legions of guys named Mike with chlamydia. So our most common atypicals, but this is not an exhaustive list by any means. So we've got Legionella, Mycoplasma, and chlamydia. And if you're like me, it was this time last year that I realised that chlamydia was more than just an STI. It can also cause pneumonia. And then we've got our hospital-acquired pneumonia. This is one that tends to affect the oldies and the post-op people as well. Like if you've been intubated for a long time, or if you're like really old and in hospital for a long time. So the most common is Staph aureus. That doesn't have a buzzword associated with it. But you would be asking on history if they were hospitalised recently. Some of the other ones include Pseudomonas, Klebsiella, which does have a buzzword, and I'll get to that, and Clostridia. And then you've also got some aspirational stuff, which sounds like aspirational. And these are your oropharyngeal anaerobes. But like I said, like I alluded to with the hematogenous spread, this is just kind of here for completeness, so don't really worry about that. Sorry, so ideally with something like this, you wanting to be looking at a lateral view of the chest x-ray, because sometimes the lower lobes, because they come down behind the diaphragm, you can't really see them, so you want a lateral view as well. It's just like in ortho, you need a couple of views to have a look. And these ones are more likely to have a normal presentation, which I'll go into in a second. And in terms of the chest x-ray, so you've got the lobar pneumonia, which I said, air bronchograms, and silhouette signs. Okie dokie. So this is atypical, and you can immediately see that there's a stark contrast between those two x-rays. So this one's more of a bronchopneumonia, and like it said, and this can have weird presentations, so aches and pains. It's not like your typical productive cough, pleuritic chest pain kind of thing. And again, I'll go through that soon. So on the chest x-ray, there's reticulonodular opacities, and these are often bilateral. So with a lobar pneumonia, it's very commonly unilateral, so just on the one side, and that's going to be really obvious to you on examination, whereas this one is can be really hard to pick up on examination because it's very scattered and all around. You can see in that chest x-ray there, it's kind of hard to describe. Like you look at it and you just sort of say, oh, it looks a bit fluffy, like perihilar fluffiness, so you can imagine trying to listen to that and trying to percuss that chest, and just you probably would be second guessing yourself. So down on that, just for completeness, the diagram on the bottom there, you can just see that there's spread bilaterally, and it's usually within the same, like on the same level. It's not, the right lower lobe and left upper lobe involvement. It's like the same level. Okie dokie. So these are our typical clinical features. So we know that productive cough is kind of like the mainstay, and like I said before, in your histories, you were asking if there's a cough, if it's wet or dry, if you're bringing anything up, what it looks like, what colour is it, does it smell funny, all that kind of thing. So cough questions are really important in a RESP history, especially if you're suspecting pneumonia. So purulent, it's usually associated with bacterial. Clear and watery can be atypical or viral. We're not really going to touch on viral pneumonia in this presentation because it's just not as buzzwordy and examinable for Monash, because there's no management. It's just supportive stuff. So in terms of other symptoms, you could be getting shortness of breath because you're not getting that oxygen transportation. Fevers goes without saying. Rigors is a really important one. You want to be like fevers, chills, rigors, fatigue, and pleuritic chest pain sometimes as well. So on examination, in terms of their observations, obviously these people would be febrile, they would be a little bit hypoxic, and they would be tachypneic and tachycardic. The tachycardia would be a result of A, the high fever, B, the hypoxia, and the tachypnea. So they may not be tachycardic on presentation. That might be something that comes a bit later. And if they're hypotensive, you want to rule out sepsis, but they're potentially dehydrated as well. So on examination, this is really, really important. We actually got an OSCE last year where we had to take a history from a lady that had pneumonia, and then we had to listen to some lung sounds, report on the lung sounds, and then tell them which antibiotic we would give to this patient. So pneumonia is a really examinable, really, really OSCEable topic, so make sure you know it front and back. So in terms of lung exam, these are the classical things that you would be seeing with a typical pneumonia or a lobar pneumonia. So you would be getting increased vocal fremitus and resonance over the lobe affected. You would be getting dull percussion, not stony dull, which is a pleural effusion. You would be getting bronchial breath sounds, because you can imagine if, also if it's the lower lobes affected, the air or the oxygen's not getting transported through those lower lobes. So you're kind of just breathing up in your upper lungs, and you would be getting coarse crackles, as opposed to fine crackles, which is more of an interstitial lung disease picture. So this YouTube video or channel that I've linked there is really, really great in terms of lung sounds. They take you through all the different lung sounds, and then actually, like, throughout the whole video, the lung sounds play, so you get a really good idea of what it sounds like, and then it just kind of explains to you why it's happening, what it's usually seen in, and yeah, it's really good. I really recommend. Okay, so like I alluded to in a previous slide, the atypical pneumonias present a little bit differently. So this is often they're said that their symptoms don't really align with the presentation or with the diagnosis, whereas atypical, they've got respiratory symptoms and respiratory findings on examination, so you're worried about a respiratory illness, whereas sometimes the atypical people, like I said, they can just have some aches and pains and flu-like symptoms, and oh my god, they've got pneumonia. So it's often a bit more gradual, slower. They can get chills but not rigors. So the symptoms are usually constitutional, like I said, so that's your fever, fatigue, that sort of thing, sort of a, flu-like picture, I would say. So patients report feeling unwell, however, there's a paucity of signs. So like I said, they don't really match, they don't really present with a respiratory picture necessarily. They can get a cough, but it develops a bit later, because you can imagine if it's really patchy consolidations throughout the lungs, they're not going to be coughing it up until the patchiness sort of envelops like a decent percentage of the lung, if that makes sense. Sputum, and again, that sort of goes along with the scant sputum and the clear. Pleurisy is really rare, again, because it's so scattered throughout the lungs, and it's unusual to find consolidation on an X-ray. Okay, so investigations. So we're breaking it down into our usual bedside, bloods, and imaging. So bedside, because people present with chest pain, or they can present with a pleuritic chest pain, you want to do an ECG. You want to do an ECG just for completeness, and you'll be seeing a sinus tachycardia. You wouldn't be seeing any other heart stuff because it's the lungs, not the heart. In terms of bloods, you're wanting to be looking at the FBE. You would be seeing an increase in white cells. That's pretty much it. CPR, that's supposed to be CRP, sorry, and ESR. I've got CPR in my mind from my doctor's ABCD that I did for management, which I'll go through in just a sec. So obviously CRP would be raised because it's an inflammatory picture, And then for diagnosis, you would be getting cultures. So you'd be doing sputum cultures, which would give you your bug so that you can give it the right drug. And then you would also be doing blood cultures as well, especially if they're, you know, they're super febrile and they've been having wriggles and stuff. You want to be doing blood cultures. And imaging, we went through the chest x-ray in previous slides. There's no other imaging that you would do. It's all on the chest x-ray. Okay, so indications of severity. This is an interesting one. So they used to teach us CURB 65, and I know that's kind of changing to CORB 65, which I'll talk about in the next slide. Because the problem with CURB 65 is the urea. You have to kind of wait for that blood to come back. But I use this one, and I guess CORB 65 is probably the same, but I use this one in terms of management. So mild, or this is how I learned it anyway, so mild, if they fit 0 or 1 of these criteria, then they can be an outpatient. You know, put them on oral benpen and send them off, follow up in a few days. If they're moderate, they get if they get 2 points, you would consider admitting them for some IV antibiotics. And if they're severe enough that they get more than 3 of these points, then you would be admitting to ICU. So for example, in our OSCE last year that I alluded to earlier, we had a female who was less than 65. She wasn't confused. We weren't giving her urea. Her blood pressure was fine, but she was tachypneic. So our diagnosis was a mild lobar pneumonia, or mild, because I think we were showing an x-ray. So it was mild lobar pneumonia or mild pneumonia. And then, you know, we have to give the right antibiotic based on that. So these are the other ones. Oh, these ones are on a timing thing. So this is pneumonia severity index. So this predicts the mortality. This is just sort of here for completeness and for your own learning. You'd never be expected to remember this or even use this, I don't think, because the number's crazy and you can remember that. So this is Smart Cop. So this is also something that they're using today. It's on the, I don't know if you guys have the MedCalc app, it's on there as well. So I don't think you're expected to remember this. But that, is a really good predictor of ICU admission. And then CORB 65. So again, with the CURB 65 Smart Cop, you need investigation. So Smart Cop's based on chest x-ray. So if you can't do it sort of on presentation or even in a GP or an outpatient setting, it's more of a in-hospital thing. So CORB 65 is probably what's going to be easiest, or whatever you remember. I just remember CURB 65, but CORB is probably the same as well. And then that sort of leads into your management. So when we get to 30 level, we need to start thinking more in terms of broader management. You can't just skip right to the drug. You have to sort of start from the beginning and list the things that you would do in order. So because these people are tachypneic, they have shortness of breath, they can be hypoxic, they can be septic, you are wanting to do a doctor's ABCD for your management. This just shows the examiner in an OSCE situation that you are thinking laterally and you are thinking about the patient holistically, and you're not just jumping to the antibiotic, which you will know, but you need to, in reality, this is what you would be doing before you administer any antibiotics. So we're working through our airway and breathing. You know, if they've got low sacs, give them nail prongs. Intubate if required. If it's a severe ICU, if it's a severe pneumonia and it's an ICU admission, they might be intubated. In terms of circulation, again, if they're dehydrated, or you know, if they're hypotensive, you might be wanting to give them some IV fluids and inotropic support if extreme. And then you would be assessing for severity. So you'd be using one of those calculators that we went through before. So if we just want to talk through an example of this, the same example that we had last year. So like a 35-year-old female, otherwise well, but her rest rate's like 45. So you'd be working through it, you said airway and breathing. So in terms of management of this patient, I would ensure that their airway and breathing is adequate. This patient's saturation is normal, but if they were low, I would consider putting them on nasal prongs and potentially calling for ICU if they needed intubation. I would also do 2 large bore cannulas and start IV fluids if I was worried about dehydration or hypotension. And then assessing the severity of this patient, she seems otherwise well, except for her raised respiratory rate, which leads her to fall into the mild pneumonia category, and therefore she could be treated as an outpatient in a GP setting. And I would give her blah, blah, blah antibiotics. And then you kind of go into more of a smoking cessation. So this is more of like a prevention, SNAP-W kind of thing. And then your general stuff, VT, prophylaxis, analgesia, etc. And in terms of risk reduction, this is a really good thing to kind of, if you have time, to tack on in your management in an OSCE, because then it shows the examiner that you know that you're very smart and you don't want this patient to come back and get pneumonia again, and you're really focusing on patient education. So pneumococcal vaccination is the one I was talking about earlier, the one that, I don't know what the age range is, but it's just old people that get it. Like no one else, there's no other population that like needs it. So treating and optimizing comorbid conditions, so asthma, COPD, heart disease. A lot of people with COPD, and you'll probably see this on the ward, have an exacerbation of their COPD. So they get like a bacterial exacerbation. So they get pneumonia on the background of their COPD. So it's really important to, if during a history comes up that they have COPD, mention something like that. And promoting hygiene, like I said earlier, sneezing into your elbow, washing your hands, etc., using tissues, throwing them away. Okay, dokie, let's get into it. So, like I said, this can seem really, really hard when you first look at it, because especially the flowchart, I've just put that there for completeness. You do not need to know that or memorize it. Well, actually, it is kind of, yeah, anyway, it's a lot of words, but essentially all you need to remember is the table on the left. The flowchart's from ETG if you're interested and you want to look it up and do your own research, that's fine. So pneumonia is one of those ones where you have to know the antibiotics. It's not good enough to say I would start them on antibiotics. You have to know which antibiotics you would start on and why. And that's when we get to our mild, moderate and severe. So that's what we've calculated with our CURB 65 or CORB 65 or SMART COP or pneumonia severity index, if you can remember all those numbers. So the way I remember it in my head, and this would be much easier if I had a whiteboard in front of me and you were all watching me draw on this whiteboard, because that's how I got taught it. So the way I remember it is A, B, C, D, D, A. So I remember this table as A, B, C, D, D, A. So for a mild pneumonia, so these are the ones that have 0 or 1 of our CORB 65, CURB 65, whatever you want to call it. So these guys, for typical pneumonia, they get amoxicillin and doxy. Amoxi and doxy, these guys are the ones that are treated in an outpatient setting, so that would be oral. And at this point, because they're in an outpatient setting, we aren't necessarily doing any sputum tests. We don't know, you might not be getting the right bug, so you would be giving both of them. And in an OSCE, it's perfectly fine to say I would give them amoxicillin and doxycycline until our sensitivities and our sputum comes back, and then I would switch to a more sensitive antibiotic. which is probably going to be amoxicillin because it's probably not going to be atypical. But anyway. And then moderate, so moderate is your benzylpenicillin or your benpen and doxy. So these are the guys that you would be considering admitting for IV antibiotics, and they have a score of 2 on the CORB 65. And you would be starting O2 therapy with these guys because their pneumonia is severe enough that they're not getting that oxygen transportation. Severe, you would be giving them ceftriaxone and azithromycin. So the atypicals are really easy to remember because 2 out of 3 of them are doxycycline. So if you can't remember, doxy is a really good guess. But azithro is, I just think of it as like a more serious antibiotic. So then it's like a severe, you would be giving it in a severe picture. So if this person had a severe pneumonia, I would be admitting them to hospital, doing all the management that we said before. I would be calling the ICU team. I would be starting them on O2 therapy and starting them on ceftriaxone and azithromycin until the sputum culture came back and we knew what bug we were dealing with and what sensitivities it had, and then we would switch to a more sensitive antibiotic, more targeted antibiotic. And that's that's an example of what you could say in an OSCE. But just remember with the severe pneumonia that this person will most likely require ICU admission, so actually say that in your OSCE. This is the kind of thing as well I should point out that it's a really good question for consultants to ask you on the wards. I had at least 3 people ask me. I got this taught to me in like week 2 by one of the residents, and then like literally the next day one of the consultants asked me, and I just felt so smart. And God bless that resident for teaching me this because I looked like a baller in front of the consultant, so it was really great. But yeah, if you can remember this table, you'll be fine. And this is for your CAP, so your community acquired. Just remember A, B, C, D, D, A. And if you can like visualize it in your head, you'll be fine. Okay, so HAP, it's a little bit different. And again, another scary flowchart. There's all this reviewing and all of these things happening. We don't go into that much detail. We just go, the antibiotic. So HAP, they start them on Augmentin, for some reason. Augmentin, so again, our mild is 0 to 1 on our CORB 65. Moderate, ceftriaxone, and severe is ceftriaxone. Again, or vanc if it's MRSA. Same thing, moderate, you're starting O2 therapy. Severe, you're admitting to hospital, you're calling the ICU, and you're starting O2 therapy. So again, with your hospital acquired, 2 out of 3 of these are ceftriaxone. So if you say ceftriaxone, it's not a bad guess. I think even if you said amoxicillin for mild, you could probably get a half mark. So if you remember that your mild is your amoxicillin and ceftriaxone is your severe, and it's just the middle one that changes, really. So yeah, but these are a little less likely to be asked. I feel like there's a lot of emphasis placed on community acquired typical pneumonias, like they're the ones that you need to know back to front. Okay, and just another little thing on prevention and prognosis. So CAP, we've already talked about the vaccination. Flu vaccine, super important as well, and smoking cessation. Prognosis, so there's a really high mortality if they're admitted to ICU because these people are really sick, and if they're admitted to ICU, a lot of times they become like intubated, and then that just kind of exacerbates the problem. Like it's just a vicious cycle. Hospital acquired, obviously our primary prevention is infection control, avoiding exposures, it all really just comes down to hygiene. Secondary stuff is the flu vaccine, and their prognosis is a little bit worse because again, these people they're in hospital for a reason, so they're already sick. They tend to be old people or people who've had surgery, so they're not at their best or at the top of their game. So their mortality is a little bit higher. Okay, so buzzwords, because we love buzzwords. These buzzwords are more about the organisms, and a lot of these are atypical crazy things that you would see in the community. So, yeah, so here we go. So rust-coloured sputum we already know is strep pneumonia. An alcoholic is your Klebsiella because, like we said before, it's more likely to be an aspirational kind of picture, and that's Klebsiella. HIV infected patient is Pneumocystis jirovecii, or PJP. You might hear PJP get thrown around, especially if you're doing an ID ward round on at MMC. And HIV patients, they tend to be infected by weird and wonderful things, so they're not going to be infected by strep. I mean, common things are common, but HIV people get the uncommon things. So literally someone said to me once, they were like, if you don't recognize one of the words, it's most likely to be the answer or something for HIV, because they just get all the weird and wonderful things. Red currant jelly sputum is super buzzwordy for Klebsiella again. So that could be, I mean, you're already thinking about a question for that. So it could be, you know, 50-year-old man who's a known alcoholic comes into the GP. He's got some aches and pains, and he's coughing up sputum, looks a bit red, like jelly. What's the causative organism? Klebsiella. Abattoirs, farmers and vets, so that's your Coxiella burnetii, that's the Q fever. Bird fancier's lung is Chlamydia psittaci, I think I spelled that wrong. Psittaci. It's supposed to be psittaci, the A and I around the wrong way. And yeah, we actually had a patient on the ward with an atypical pneumonia, and atypical community acquired pneumonia, and we were taking a history as part of our CBT, and someone asked, they were like, oh, do you have birds? And he's like, oh yeah, I've got a whole aviary, I just cleaned out the birdhouse the other month. And my CBT's jaw dropped because they couldn't figure out how this person had a chlamydia pneumonia. Like, no one else in the hospital had figured it out, and it wasn't until like one of the med students who had remembered these buzzwords asked the question that they figured it out. So that's pretty cool. Air conditioning, so any sort of like aerosol or damp or water is your Legionella. I kind of remember it like Legionella, I don't know, Alpha Lake Legionella. Teenagers, dorm room, that's your Mycoplasma pneumoniae. So that the stem for that could be a bunch of 18-year-olds that live on residence at university are all coming down with a pneumonia. What's the most likely causative organism? And that's your Mycoplasma pneumoniae. So yeah, that's pretty much it. Don't worry about these buzzwords too much. It's all, I mean, these are really easy sort of MCQs that they could potentially give you, but they're not as OSCEable. Like I said, the common things are common. They're never going to give you an OSCE with an alcoholic patient that's coughing up red currant jelly, and they're going to ask you about Klebsiella, because it never happens. They're going to ask you about strep pneumonia. They're going to ask you like a typical lobar pneumonia, because then they can ask you about the management, because we don't know the management for this. It's just, so yeah. Look at lots of YouTube videos. There's lots out there. Osmosis does a really good one. Armando Hosodogan does a really good one as well. Yeah, happy studying. I hope you all stay healthy and well, and hopefully we'll see you very soon. Thanks, guys.